Welcome to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, and I am back in the Sunflower House for another new edition with a very special guest. And I want to welcome Dr. Alison Stout. And let me share a little bit about you. She's very fascinating. I didn't even know about her field, specifically what she's done until very recently. So I'm very excited to have her on this podcast. She is a physician and a colleague of mine at the Cleveland Clinic in Cleveland, where she practices spine and musculoskeletal medicine. And she also engages in clinical research and teaching. She specializes in comprehensive, non-operative spine and musculoskeletal care, including fluoroscopically and ultrasounded guided interventions. She earned her medical degree from Kirksville College of Osteopathic Medicine before completing a year in training at Johns Hopkins in Baltimore, Maryland. And then following her physical med and rehabilitation residency at the University of Washington, she completed a musculoskeletal medicine and interventional spine fellowship in Bellevue, Washington. She is board certified in physical medicine and rehabilitation and sports medicine. Welcome to the Speaking of Women's Health podcast, Dr. Stout.
Thank you so much.
Tell us a little bit about yourself personally. That's all your impressive physician credentials. Anything personally you'd like to tell us about yourself?
Well, it's kind of a physician credential, I guess, in a way. It's I'm newly the president of the International Pain and Spine Intervention Society as well. And that's exciting. That's a personal achievement of mine. I love it. It's a passion of finding evidence in what we do.
Well, congratulations on that.
Thank you.
So tell us, what is regenerative medicine and what are some important caveats?
Regenerative medicine, especially for spine and the musculoskeletal system, is kind of a hot topic, right? People are really excited about it, and it has been for a couple decades now. But the thought of, taking damaged or aging tissue and then renewing it, right? Like let's get those joints feeling better. Let's get those discs feeling better, get them looking better, all that. And with that, that excitement has come a lot of people capitalizing on it, right? So the one thing I want people to understand is there's a lot out there that's not what it says it is, right? So regenerative medicine is exciting, and the research continues to be, something to look forward to, and it's not where we need it to be for mainstream use. So all those ads out there, all the stuff out there, say on the street, or at the office down the street, or on every other corner in some cities, may or may not be providing something that's scientifically proven, right? So there's kind of a hidden crisis in regenerative medicine. There was an article actually published in Pharmaceutical Technology just 2 months ago, and it's about this FDA crackdown on enforcement of regulation on regenerative products. And one of the most alarming issues uncovered by the FDA was this growing corruption happening within the regenerative biologics supply chain. So the products coming into these clinics. Yeah. So they repeatedly revealed concerns with mislabeled or falsified tissue origins, improper or missing donor screening.
Yikes.
Illegal tissue processing.
Ooh.
So for example, several products that were being marketed as, quote, umbilical stem cells or Wharton's jelly contain 0 live cells, poor quality tissue fragments, degraded proteins, no traceability at all of what products they actually were. There were even cases where the tissue source listed on the vial didn't match at all what was discovered during inspection.
Oh my goodness, that's horrible.
Right. Yeah, and so patients don't know, and even the clinics themselves that are purchasing these products don't necessarily fully understand that several of the quote unquote stem cell products sold even in the United States regenerative market aren't what they claim to be, right? And so in this expose article, they actually said, anytime you go to see someone or you walk in, you're telling your patients, hey, you can try these things. They might not harm you, but you should ask these 3 questions always. And that's 1, what FDA registered lab manufactured this product? And if they can't answer it, do not proceed. Can you provide the donor eligibility form, certificate of analysis, and the lot number? And all these documents should match the bio of the product. And then the 3rd question, finally, a clinic should be able to provide the lab's most recent FDA inspection report, or what's called a 483 letter. And to me, these are non-negotiables, right? So if you are in the US and you want something done regeneratively, by all means, please ask these 3 questions, because at least then you won't get, injured.
Yeah, boy, that's really a concern. I mean, as my patients know, women come in to see me, I expect them to bring in just their regular prescriptions that I prescribe to them or other physicians have, as well as their supplements. I'm always looking for a lot number expiration, because if something's not a food or a drug, it's not regulated by the FDA. So are these stem cells not regulated, or they are regulated because they're biologics?
Yeah, so a lot of them, if they're minimally manipulated, are not regulated, right? So say you go into a regenerative medicine place, they could take your adipose tissue.
Oh, they can take all mine. I'll volunteer.
And they may try to call it a stem cell injection, but it's not really, because they're not allowed to manipulate it to the point that it's a drug. So a lot of these, on the corner places like not Cleveland Clinic, there's a reason I tell people they want, can I do regenerative medicine? If it was well proven and we had a product that really worked, we would have it here at the Cleveland Clinic. They would have it at Johns Hopkins. They would have it at Mayo Clinic. And we don't, because there's not, outside of a study right now, as far as stem cells in kind of the biologics go, other than platelet-rich plasma, and we'll get to that. But other than platelet-rich plasma, there's really not a lot out there that's proven, and if you don't ask, about the certification and all that, could be dangerous. More likely than not, it's going to be costly and not help you rather than hurt you. But I do like to throw out this cautionary statement first, because everybody gets super excited about regenerative treatments. Oh, sure. Right? Yeah. One of the biggest ones is, the disc, right? Our discs wear out.
Oh, yes, they sure do.
And there's nothing to fix it. There's no surgery that fixes disc wear and tear, disc degeneration, the typical aging process of the disc. There's no procedures we have, from pain perspective. So it's kind of this holy grail of people trying to figure out what to do with this disc. I mean, that's one of the main ones. And, for right now, there's several studies ongoing that are, phase 3 clinical trials, and Cleveland Clinic's part of one of those. But outside of that, for the spine, really, unless you're part of a study, there should be no stem cells being injected into your spine, for sure. Yeah.
And I have heard of, and know of some patients and people who have extra money to spend, who leave the country for infusions and things that sound a little bit specious to me. Is that what you think they're doing? They're leaving the country to get stem cells?
Well, the problem is, again, you don't know what you're getting, right? Because it's not regulated by any. So you leave the country and there is no regulation, right? So a lot of these companies have moved away, that these countries that may not have your best interest and really just have the bottom, the money interest, the capital gain interest in mind, they will take their product and do an offshore clinic. That being said, there's plenty of countries where they're doing things correctly. However, I caution that they don't have the same oversight as the FDA, because the FDA only operates in the U.S. So when you go offshore, then the issue is then you have they are not going to have an FDA 483 form. They're not going to have anything to prove where this tissue came from, and how they, let's say if you have your own stem cells that they're trying to do, then how they're manipulating those cells and in what capacity is a question. Most of what have been studied now, for at least from stem cells for pain and spine and joints, are cultured stem cells, right? So they grow them in a lab that's very controlled. There are a couple places where those could be injected that could cost you quite a bit of money, like I think in the US. But most, I would say 99.9% of them, if you're having stem cells injected in the US, are going to need to be part of a study. Right?
A study, being part of a research study.
Yeah.
So
they're just not available outside of that. I had a patient looking, he wanted to try it, right? If he wanted to try it, he wanted to try it. And the only way he could have it injected was to be a part of a study, the one that he wanted. Yeah.
Yeah, we've had in season 3, we had a rheumatologist talk about PRP injections and how they're not FDA approved, but there is certainly some evidence, and that's a way that people with musculoskeletal problems, a lot of athletes, people with injuries may pursue that. I know my sister just had it done. She's like an Olympic level rower and injured her shoulders. I'm like, why don't you just cut back on this? I don't know that your shoulders are made for it, And she's like, no, I have to keep going. I'm going all around the world to compete.
And that's awesome.
Yeah. So, she went and had PRP and was happy about it. So can you, do you end up, in your field, do you do PRP in the spine? I know it's done in shoulders and knees and hips and...
In my prior life, I did before the Cleveland Clinic. We don't have that set up, but I know the orthopedic department does use PRP injections for joints. And we're working to get it set up to be able to do it for spine if someone really wants to. The places where it's studied in the spine are the joints in the spine. So the sacroiliac joints and the facet joints. PRP in the discs haven't been shown to work. There's and evidence in the other parts is very, very limited. But it's better than stem cells and it's cheaper, right? And so I do think that PRP is not, it is actually somewhat reasonable. Its cost is lower, its risk is lower, its likelihood of having some positive effect is higher than with a quote unquote stem cell product.
And so for our listeners, what we're talking about, PRP is plasma-rich platelets. So blood is drawn from the patient herself or himself, then it's spun down, and then that same serum that has like growth factors and platelets is then put back into the body in a certain place to try to facilitate healing. Is that right?
That's correct. And so it's used in joints and in tendons, like your sister had in her shoulder tendons.
Because tendons are so slow to heal. Although we did have a podcast on acupuncture, and I had acupuncture for a tennis elbow, and I was really happy with that. But
oh, absolutely, even dry needling. Yeah. So the study that threw PRP, platelet-rich plasma, under the bus was actually that insurance said we're absolutely not covering this, was a study that compared just dry needling the Achilles to platelet-rich plasma in the Achilles and showed they were equivalent.
Wow.
Right. So.
And one is much cheaper.
Cheaper, right?
Although I don't understand, why is it expensive if you're just drawing off the patient's blood? Is the machine to spin it down, or is just everything inflated?
Well, it's both. It's both, right?
Yeah.
It's the kit. It's the procedure suite. If you have ultrasound guidance, it's not as expensive as if you had fluoroscopic or X-ray guidance. And in platelet-rich plasma, there's still, you look at the studies on it, and it's still so difficult to tell what is best practice. So there was a review article that looked at, what in for platelet-rich plasma injections of what and how often and all that. And there's still so much that needs to be researched that we don't know the answer to. So for just a couple examples, we don't know the exact number of platelets we need. We think the goal is around 1.5 million, and there's some studies that suggest too much more than that. It might have an inhibitory effect. It might not help you as much, right? So there's That we don't know. And then in a single person, like my growth factors might not be as good as yours. And so if I have PRP, it might not work for me, right? Because my growth factors have some sort of congenital problem, some genetic issue already, right? That's why I had the tendinopathy in the first place, right? So there's that. And then there's questions of like there's two types, leukocyte rich versus leukocyte poor. And I think that's really important for people to understand, because that is something we know between, say, injecting the joint versus the tendon. When you inject the tendon, you want an inflammatory response. So you do the leukocyte rich. And then if you want it in a joint, you don't want to stimulate too much inflammation. And so you do leukocyte poor. And even a lot of physicians aren't really aware of that. And they're doing platelet-rich plasma injection with the same kit for everything. And it may not be helping, right? Yeah. Other questions like, what if you use local anesthetic? Well, local anesthetic has been shown to inhibit platelets, right? So there's data that says you shouldn't inject with a local anesthetic when you're doing this, because it could inhibit the actual platelet activation and the growth factors. So there's still a lot of questions in that. There's still some evidence, and I think it's reasonable. It's not unreasonable. So let's take a real world example. Sacroiliac joint pain. We know we can inject that joint. We inject it with x-ray guidance for the most part, and we put anesthetic and steroid in it. Well, we know steroids have limitations, right?
Yes.
Yeah. So you say you get an injection and you get relief and it lasts 3-4 months. You get another one, it only lasts 2 months. Well, we're not going to keep doing this, right? The only other treatment that's currently paid for is SI joint fusion. Okay, so you're going to go from a steroid injection to a fusion. To me, if I'm in that boat, I might think about platelet-rich plasma. There's a little bit of evidence. Maybe it works. It's going to cost me money out of pocket, but then I can avoid a sacroiliac joint fusion, which in women's health, we know that SI joint fusion hasn't been around that long. I honestly wonder what will happen to especially women who have their SI joints fused once they get a little bit osteopenic. Are they more at risk for a sacral insufficiency fracture? We don't know this, right? We don't know what will happen to these people when these young women who are 30s and 40s who have an SI joint fusion on especially both sides, and then when they're osteopenic at 75 or 85.
Well, hopefully, if they're listening to the Speaking of Women's Health podcast and they've heard a lot of our podcasts on osteoporosis, they won't get to that point. But what an excellent point. And you've been listening to the Speaking of Women's Health podcast. I'm your host, the Executive Director, Dr. Holly Thacker, and I'm speaking to a Cleveland Clinic colleague, Dr. Alison Stout, who is an interventional spine, physical medicine, and rehabilitation physician. And we are talking about regenerative medicine for spine care. I had a colleague who almost had to retire early because of severe SI joint pain. And certainly the spine, it just seems like it maybe wasn't as well designed for us bipedal humans as it should have been, because so many people have spine problems. In fact, one of my most listened to podcasts, and I am not a spine expert, but my brother said, I'm having sciatica. Do a podcast on this topic. I had a girlfriend who was like laid up and couldn't even walk and was in severe pain. And all these people were like, you've got to get some good information out about the spine. So I just kind of did the basics. But tell us, what are some of the treatments that you're using in your interventional spine treatment practice?
So we use a lot of diagnostic injections and then radiofrequency ablation. So for joint pain in the spine. So that is
if you can locate where the pain's coming from.
Where the pain's coming from, right?
Does ablating those nerves damage them so that then they don't function anymore? Does that cause muscle weakness or?
That's a really good question. So for the facet joints, we ablate the nerves, and they do have some innervation to the multifidi muscles specifically, which
stabilize
in the low back stabilize the spine.
Yeah.
Right. And in the low back, if you only do a couple joints, not the whole spine, what we found is that doesn't have any repercussions into function. Like, so they did a study where they had radiofrequency ablations and they were successful. They proved they ablated the nerves. They did EMG that showed they had denervation in their multifidi, and they had an MRI, and the radiologist couldn't predict where the ablations were at based on the MRI, because when we're older and in pain, our multifidi atrophy anyway, most likely. So yes, there is some of that. These nerves grow back, however, right? So it's not a forever thing for the facet joints. A more recent ablative technique is called basovertebral nerve ablation. And so this is a newer concept that has come up in the last 6 years. So we talk about the disc, and what they found over the last 6 to 10 years is that the end plates on either side of the disc have pain sensors and are often actually the cause of the pain. And our Cleveland Clinic person, Dr. Modick, they're named after him. Modick changes of the end plates, the end plate degenerative changes are markers that someone might be a candidate for this. So if someone has just back pain without the sciatica, they shouldn't have sciatica with this. They might be a candidate to have a radiofrequency ablation to treat their pain in their facet joints or around the disc in what we call the end plates. And that the basovertebral nerve ablation is a little more intense. You have to get into the vertebral body, which requires, access through the pedicle, similar to like a kyphoplasty or something like that. But most patients tolerate it really well. And about 75% of people get good relief of their back pain who have been well selected for this. And again, it's not 100%, right? So it's good and it's a newer thing, but it's for a very specific subset of patients. And I would say in both those treatments, the regenerative piece is then you have to couple that with function, exercise, movement.
Oh, yes, always. You have to do the physical therapy.
Well, and what I want to drive home is the regenerative capacity of your body is only unleashed when you are active, right? So let's take, for example, the disc. The disc, you can promote regeneration with activity. You don't need a regenerative injection, right? And of course, you can overdo it with activities and you can cause an injury or things like that. However, there's that medium thing where if you're sedentary, you are not utilizing your own internal regenerative medicine, right? So I think any of these treatments that are for pain that we do injection wise, whether that's a steroid injection or say a radiofrequency ablation or denervating something, the goal is then to couple that with improved movement for health reasons, for regenerative reasons, for everything, right? But what we don't want to get into is, we just do this procedure and that's all there is. That's not how these things work. They work together. Yeah.
So it really has to be a comprehensive program with probably physical therapists, the primary care physician involved, good nutrition, good sleep hygiene, all of that,
good bone health, right? All that, right?
I'll see patients who have some sort of invasive spinal procedure or hardware placed or kyphoplasty, and I'm an osteoporosis expert. And then they'll have a fracture above or below the area that's under stress, and their bones are still very unhealthy.
Right.
And so even if you mechanically fix, like one part of your house, if the rest of it's falling apart and is a mess, the structure, it's going to be a big problem.
It's a huge problem. And I think on the same line of interventions, we've come to find out that the steroids we inject are absorbed into your bloodstream, right? So there's systemic absorption of these steroids with the same bone density effects as if you took them by mouth. Now, we don't know the exact number, but I'm part of a multi-society work group that has a consensus guideline that's being published that talks about it. It's already been done about the joints. and in that is a little bit about the data on epidural steroids. But basically, women with osteopenia or osteoporosis and men in that same age group, so basically women at 60 and men at 70, really shouldn't have more than around 150 milligrams of injected steroids in a year. And for most people, that's not a problem. I think it's more the awareness, right? That you can't have a steroid injection in your shoulder because you want to row and then have your back done and then your hip, and then you have all three repeated 3 times in a year. That's too much.
Mm-hmm.
It's being reasonable about these things and making it part of a bigger picture for your overall health, I think is again, we're circling back to that. Everything we do has a side effect, right? Yeah.
And are there instances when a patient should not receive some sort of regenerative medical therapy?
I think there are instances where people shouldn't have regenerative medicine therapy. I mean, one, if you don't have a good target, that would be probably number one. So I had a patient who wanted their neck injected for neck pain, and their pain was everywhere, and they had hypermobility syndrome of some sort. And I spent a lot of time with them explaining that you can't. One, you have to have a very specific target when you're talking about regenerative injections.
Mm-hmm.
And two, when you have like a hypermobility syndrome, there's unlikely to be a single target. And we don't know with, congenital genetic problems with collagen, will regenerative injections even help at all? Yeah. So I would say that would be number one, but that also goes for, say, uncontrolled systemic illness, say diabetes would be number one, right? Because your body can't function well. So if you have uncontrolled blood sugars, that's also a situation where you don't know what's going to happen to those cells. It could be good, it could be not so good, right? So, and then, yeah, I think it's also having the right target, you've done all the stuff to have the good outcome, right? You're exercising, you've got a treatment plan in place, and you can't be on anti-inflammatory medications when you have regenerative injections. You can't be on NSAIDs.
Yes, like
you can't have
aspirin and Motrin or doxycycline. Yeah, it's going to inhibit the response.
Right. You can't have a recent steroid injection, right? Mm-hmm. So everything has to be lined up. So you really need someone working on the whole not just, let's put this needle in this spot that hurts, right? So there has to be a bigger treatment plan.
So are there any online resources that you can, because we have listeners in 100 different countries, where there are people that are trained in spine intervention and helpful tips or further education about stem cells, about PRP, about blocks in the spine or those kind of therapies?
That is a really good question. I know of no such resource online for regenerative medicine. A lot of what's out there has conflicts because it's company, right? So
okay, so they're selling.
Yeah, they're selling.
Any like social media or online resources like that the Clinic Spine Center has, or do you do any social media or any like public?
I'm horrible at
education. No, okay. Is there any listeners that are in the Ohio area or want to come to the Ohio area, how they can make an appointment with you, or do they need to see other physicians to be specifically referred to you?
Oh no, I'm happy to see people. They can schedule with me or one of my spine colleagues. I can give that number. It is 216-636-5860.
So we'll put that in the show notes. Or any links to this society that you're a president of. Do they have any patient resources, or just all professional physician?
That one's professional. The other organization that I'm involved with that does have patient-facing resources is North American Spine Society.
The
So
North
they
American
have,
Spine
yeah. So
Society.
NAS, North American Spine Society, has patient-facing, and then IPSIS, or International Pain and Spine Intervention Society, has more physician-focused, and that's more, a lot of what that organization does is the evidence, and it does have things about regenerative medicine. They're not big on it, right? Because it doesn't have a lot of data, and that organization is very heavy on practicing science-based, evidence-based medicine, with high standards for, say, correct injection practices and things like that. Yeah.
And any comments? We have a lot of physicians and clinicians who listen to our podcast as well. For anyone who might be interested in entering this field, I assume it's pretty high in demand.
Yes. So one, the field of regenerative medicine means that you have a basis in all, the art of knowing when it's appropriate, right? That's like everything. It's like, yeah,
Mm-hmm.
you can do the injections, you could do regenerative medicine, and you need to have the basis of what the other options are, what the medicine is behind it. So, I recommend that people do fellowship in pain and or in spine and musculoskeletal. There's ACGME options, obviously, for fellowship training. There's non-ACGME. For people in other countries, there are training programs for interventional. There are several, because I know in like Europe, there's no intervention spine musculoskeletal interventional fellowship program. So there's programs for training in several countries, and I could list some of those resources. I don't have them offhand, but I can
Well, we
put
can
them.
we can get them in the show notes.
Okay.
Well, thank you so much, Dr. Stout, for joining us today. And thanks to our listeners for tuning in. If you haven't already, please share this podcast with your friends and your family. And if you enjoyed this episode, give us a 5-star rating or write a review. And we'll be back next week for another episode. Until then, remember, be strong, be healthy, and be in charge.